We're going to be ready in 1 minute. No.
Yeah, you're fine.
I know.
This is the only thing that needs to be out.
It's that freaky thing.
Yeah, no
where
worries.
Since you
You're
said don't
expecting
sign
to,
in
yeah.
or anything like that, then
I just want to make sure this doesn't get.
okay. Because I'm used to seeing something.
Yeah, of course.
And that's gonna bug me. All right,
Okay.
got
I
it.
can turn it. I can make it so it's blank if you want.
No, it's okay. It's okay. We got it. Welcome. Welcome to Nursing Grand Rounds. Welcome to Nursing Grand Rounds, a continuing education opportunity supported by Friends of Nursing. I'm glad you're here. I'm Jana Alexander, Director of Special Programs for Duke University Health System Nursing. The Friends of Nursing Scholars Committee uses the results of an annual survey to plan these activities like nursing grand rounds and seminars. And year after year, no surprise, the topic of ethics ranks very high on that survey. Just this past month, on February 8th, we had a day-long seminar on ethics, doing what's right. And Dr. Rosoff, today's speaker, was an integral part of that day. And he offered to kind of bring it home and do a 1 hour today for us for Nursing Grand Rounds so that we can hear what's most important. For today's activity, to get credit, you'll receive an evaluation via email, likely by the end of this week. You'll need to complete that evaluation, and then you'll have the opportunity to print your certificate if you choose or save it, and then also it will show up in your educational record. Philip M. Rosoff is Professor of Pediatrics, Hematology and Oncology, and Medicine at Duke University Medical Center and School of Medicine. He is a resident scholar in the school's Trent Center for Bioethics, Humanities, and History of Medicine. He is also Adjunct Professor of Clinical Sciences at NC State College of Veterinary Medicine, where he was a co-founder of the college's Clinical Ethics Committee, the first such body at a tertiary care veterinary hospital in the world. Dr. Dr. Rosoff has been chair of Duke University Hospital's Ethics Committee and Ethics Consultation Service since 2005. His scholarly work focuses on the equitable allocation of scarce resources. He is the author of 2 books, Rationing is Not a Four-Letter Word, Setting Limits on Healthcare, and Drawing the Line, Healthcare Rationing and the Cutoff Problem. He is currently working on his next book, entitled Doctoring in America, The Rise and Decline of American Medicine. Welcome to Dr. Rosoff.
Thank you, Jana. So, welcome everybody. Thanks for coming out. Who gave the shout out to NC State? Were you an NC State lover or a puppy lover or both? They're not mutually exclusive. So that's really a cool thing that we do over there. I'm very, very pleased with it. Not least of which because I get to go over there and see the puppies every month. So, I want to thank the organizers of Nursing Grand Rounds for asking me to speak this morning. However, this occasion is somewhat bittersweet for me, as this will be the last time I have the honor and privilege to talk to you in this format, as I'll be retiring in, let me just see if I can get this correct here, 95 days, 13 hours, 55 minutes, plus or minus 50 seconds. Okay.
Congratulations.
Thank you. I can't decide if the round of applause is to thank goodness I'm retiring or... There are many things I will miss about working at Duke, and one of the most significant has been the many collegial relationships I've developed over the years with nursing staff. There's little question that you all are what makes this place special, and our patients and their families are the better for it. That being said, however, not all interactions between nursing, physicians, trainees, all of us, and patients, families, and visitors are as we might wish them to be: cordial, mutually respectful, and civil. The questions that come up about people behaving badly, meaning behaving in such ways that they are disruptive to our mission of caring, are many, and they include: how should we respond to these situations? Are there measures we can adopt to recognize developing situations early and nip things in the bud before they spiral out of control? And what can we do to protect our personal and professional integrity and sense of self-worth when verbally and even physically assaulted because of who and what we are? I hope that my remarks can begin a conversation, although I have little doubt that many of you have been thinking about this topic, if not dealing with it, or trying to deal with it, on a daily basis for some time now. If anything, things have gotten worse and more intense over the past few years. While I admit this is a very pessimistic view, I think it unlikely that current conditions in our country that predispose or even encourage bad behavior towards others will lessen anytime soon. So, we must do what we can to protect ourselves and our patients and maintain the high professional standards that we rightly hold dear. Now, some quick bookkeeping. In giving this talk, I will be doing something unique in your experience for most of you, perhaps even revolutionary. As you notice, there's no slide projector. I will not be using PowerPoint slides. So you're going to need some other mechanism to pay attention or even stay awake. Maybe you can buddy up with your neighbor in a pact of mutual anti-somnolence with the agreement to poke each other if you notice your partner is nodding off. Of course, if you're both nodding off, that could be a problem. For my part, I will do my best to keep this talk intellectually stimulating and perhaps even entertaining, albeit visually boring. But let's hold questions until the end, at which time you can let loose, at least those of you who are still conscious. I do realize, after all, that it's mid-morning and the AM caffeine effect has likely worn off. So, on with what I have to say. Rising from the ashes of centuries of European religious warfare, that resulted in the slaughter of hundreds of thousands and perhaps millions of people, the Enlightenment grew out of the need for people of diverse values and beliefs to live together in a semblance of peace, if not harmony. The liberal polity that evolved has been remarkably successful in reducing religious strife. This is not to say that people do not engage in orgies of mass killings, such as in the two world wars of the 20th century, just that these wars have generally not been fought over differences in the gods that people pray to or the rituals of orthodoxy that they practice, but for political reasons. Nevertheless, we can see modern-day remnants of the consequences of religious intolerance in the wars engulfing the Middle East, with different adherents of Islam killing each other over the proper interpretation of their shared faith. Like the disparate versions of Christianity in medieval and Renaissance Europe, where sect battled against sect, current religious wars of prejudice are fought for similar reasons. If anything, the Western adoption of political liberalism has enabled peoples with different interpretations of the good life to mostly tolerate each other's principles and live together in relative peace. But if liberalism means anything, it is the predisposition to tolerate views one can't abide and peacefully cope with minority beliefs. It is in this middle space that civil discourse takes place, in which there is a shared commitment to secular values that generally pertain to how civic life is conducted and administered. Yet there is a constant tension in this arrangement, in which tolerance is tested and the majority's willingness to countenance the philosophy and ideology of others who differ in what they hold important and sacred may be limited. Indeed, it is within the power of the majority to define the boundary of what they can put up with. Alexis de Tocqueville, in his still trenchant and perceptive study of early American democracy, noted the potential pitfalls of what he called the tyranny of the majority. And he was by no means alone in his concerns. Many of the framers of our Constitution worried about the rights of the minority suffering at the whimsies, and passing fancies of the majority who wielded power and designed the document, and especially the Bill of Rights, to protect those rights as inviolable. But the protection of these rights, the rules that govern how we behave in public, and to a certain extent private spaces, are under attack. Some even believe they are eroding to produce an environment where being someone different or not a member of a majority group can actually be dangerous. Insults and increasingly physical attacks on the basis of what kind of disfavored group you are perceived to belong to are becoming commonplace. And you all know that those doors to the clinics and the hospital don't keep this stuff outside. Civil discourse and behavior between people from different backgrounds can only occur when there is an assumption of mutual respect and equality between the parties. If one person believes the other to be inferior or lower in some way, as for reasons of ethnicity, skin color, religion, etc., there cannot be true civility, only minimal toleration, if even that. This may be sufficient in the short term if it keeps derision, disgust, and dislike under control. But in situations of high emotions and psychological tension, as often occur when people or their loved ones are sick, or when the societal etiquette or rules that we adopt to moderate immoderate behavior becomes less constrained or loosened, as now appears to be happening in many places, language and behavior that was previously unsayable and unthinkable, except by the most illiberal, becomes liberated. Hence, the entire social basis for people from different backgrounds and different commitments to what they think constitutes a good life to engage with each other in a civic space, be it in politics or in the hospital, breaks down. The question then is, how do we control our environment so that we can fulfill our moral mission to relieve suffering and heal the sick, no matter who they are, if we are insulted or endangered by the very people we are devoted to serving? And while I will focus on verbal behavior, my analysis and prescriptions apply to threatening physical behavior as well, if not even more so. Perhaps unsurprisingly, the increasingly fractious politics in the United States is reflected in the public sphere through newspapers, magazines, and especially online media. Many Americans have remarked that discourse has become coarsened and that previous constraints on what people felt comfortable saying openly have been loosened. The old rules seemingly no longer relevant. Accompanying this flurry of communal, open, and widely broadcasted and available opinion and vitriol is the not surprising rapid growth in hate speech, and more frighteningly, hate crimes. Indeed, at the end of last year, the FBI reported that hate crimes increased for the third consecutive year, with ethnic and religious minorities being the most frequently targeted groups and individuals. One possibility is that the sheer number of jerks has increased, thus accounting for the increase in incidents of incivility. Another possibility is that the filters have come off, so that those people who would have previously kept their mouths shut and their hands to themselves somehow feel at liberty to say what they feel and do what they feel no matter what. Or, a more frightening likelihood is that current conditions not only breed incivility with an expanding number of racist, homophobes, anti-Semites, Islamophobes, etc., and combine it with a social climate that gives them free rein to vent their odious views both verbally and physically. It may not be remarkable, then, that this breakdown of civility has extended to the healthcare field, and that patients and their families are now frequently seen to have fewer compunctions against making offensive demands for all sorts of things, not least of which is the kind of doctor or nurse who cares for them. After all, everyone, irrespective of her views of others, is susceptible to illness and injury, and as medical professionals, we have entered into a covenant that we will care for all who need our help, even if we don't particularly like the patients before us or find their views reprehensible. Often, racist or discriminatory demands would not be problematic, as individuals are in general free to select their physicians, and to a certain extent, under certain circumstances, nurses as well. But in a team practice setting such as in a hospital, trying to choose caregivers on the basis of prejudicial biases, demanding that one be treated only by a caregiver of the same ethnicity or sexual orientation, for example, can be problematic. Let me illustrate this challenge with a real case. Tonya Battle started working as a nurse in the neonatal intensive care unit at Hurley Medical Center in Flint, Michigan in 1988. In 2012, as she began caring for a newly admitted baby, the child's father asked to speak with her supervisor. He told the charge nurse that he did not want Battle caring for his child because she was African American. Indeed, he did not want any black caregivers. While he made this request, the father, who was white, reportedly showed the charge nurse a swastika tattoo on his forearm, presumably to buttress his bona fides as a racist. The charge nurse then brought this to the attention of the nurse manager, who reassigned the patient to a white nurse. The case was escalated to higher management, which agreed to the father's demand. The staff was informed. A prominent statement was put on the patient's shift assignment seat, and it read, quote, "No African American nurse to take care of baby," end quote. Battle sued the hospital in state court and filed a complaint with the Equal Employment Opportunity Commission, alleging employment discrimination in violation of Title VII of the Civil Rights Act of 1964. The case went to the Federal District Court in the Eastern District of Michigan in the Southern Division, but was withdrawn when both Battle and Hurley reached an out-of-court settlement, and there it ended. Most of us working in healthcare are concerned, perhaps even appalled, when patients make demands for doctors or nurses or other caregivers that accord with their bigoted sentiments. Even though there may be some reasons to believe that matching certain characteristics of doctors with those of their patients, whether the latter asks for them or not, may produce both more patient satisfaction and even some health benefits, how does one tease apart or distinguish requests that are potentially beneficial from those we find abhorrent? What facts might make it acceptable for an African American patient to request an African American doctor, or a Chinese Mandarin-speaking patient to request a physician who is fluent in Mandarin and is also of Chinese ethnicity? At the same time, why do we recoil or find it objectionable that the father of the baby under Tanya Battle's care in Michigan might want a nurse caring for his child with whom he identifies ethnically or racially or religiously or based on any other superficial trait or traits that we use to characterize people? Clinicians and hospital staff members might view these demands through a modern lens skewed by adherence to the perceived requirements of patient satisfaction grades, especially in the era when hospital reimbursement may be affected by adverse scores. In a competitive hospital market environment, some hospital administrators, physicians, and nurses might believe that accommodation of the desires and wants of the patient, so-called customer service, must rule the day at the peril of negative comments. Indeed, my experience here when crafting a policy to deal with such demands, this was 9 years ago, revealed the degree to which administrators are hypersensitive to what they perceive to be the imperatives of patient satisfaction. And we can talk about this more later, as I think it is a major complicating factor. One major facet of patient satisfaction is the assumed elements of patient-centered care, some of which may be the embodiment of what are called patient rights. It may be worth remarking, both parenthetically and perhaps somewhat cynically, that I was under the impression that we were in the business of doing patient-centered care well before we invented a name for respecting the legitimate needs and concerns of our patients. Nevertheless, in one of the only empirical studies to address provider attitudes toward patient, gender, and race-based requests and accommodation or not, Padella and colleagues surveyed some attendees at a national meeting of emergency physicians in the United States. They found that about 1/3 of the physicians would agree to requests for same-gender providers, especially if the doctors were female, and much fewer for same-race requests. About 1/4 agreed that accommodating patients in this manner could lead to better care. In a related study, Jessica Green and her colleagues queried a convenience sample of U.S. adults about their likelihood of choosing a physician based on his or her perceived race, ethnicity, or gender, and on whether knowing how good a doctor he or she was based on provided quality metrics information, and how that would influence the result. They found that respondents who identified as white and male were much more likely to choose a race and gender concordant doctor, while ethnic and racial minorities were unlikely to do so. But why? As Kyle Anstey and Linda Wright point out, the rights or expectations of patients and their families to respectful care in which their needs have primacy must be tempered by some corollary needs of their caregivers to be treated with some modicum of courtesy and respect. They argue that there must be, quote, unambiguous messaging to both parties, end quote, meaning patients and providers, about expectations and limits on behavior. And as nurse and lawyer Edie Browse points out, quote, it's important to make a distinction, however, between a patient requesting the provision of a cultural accommodation and a patient requesting the exclusion of certain providers on the basis of ethnicity, race, or other characteristics. Patient-centered care cannot be the rationale for granting such requests, end quote. So for them, the staff and the institutional response would seem reasonably straightforward. One cannot justify, either legally or morally, complying with racist requests. Indeed, Penn State Health at the Milton S. Hershey Medical Center has adopted just such a policy with zero tolerance for such demands. But it is more complicated than initial appearances may suggest. Of course, not all racist demands are the product of rational thought. While no less superficially abhorrent, racist requests to exclude certain providers may be the products of a mental illness of one form or another, and hence excusable in the moment. This is not to say that patients who make such requests while mentally ill may not be bigoted if and when they return to some plausible level of rationality. It is simply that while they are in a mental state in which we would ordinarily not hold them responsible or accountable for either their statements or actions, we should not necessarily respond to them in the same way we would to an individual in full command of his or her faculties. Although accommodating a demand that is based on a patient's delusion, for example, might not be required, doing so might be practical for reasons of personnel safety. I recall a case of a hospitalized Vietnam veteran right across the street who suffered from severe post-traumatic stress disorder and who became violent at the sight of individuals whom he interpreted as being Vietnamese, presumably with facial features that he viewed as Asian. The care team decided to ensure that no doctors, nurses, or aides caring for him could provoke him in this manner, primarily for reasons of their safety. It's also important to recognize that seemingly bigoted demands may not be static and fixed, and that the patients making them could be amenable to moderation with experience or education. For example, data shows that initial impressions of what one wants in a doctor, especially the superficial characteristics that are the basis for discriminatory requests, can be overcome in some instances by demonstrations that even the wrong kind of physicians may be kind, understanding, and empathetic, and therefore the kind that you might want taken care of you. A distinction might also be drawn, and I should note this may be a fine one perhaps, but a distinction nonetheless, between preferences and demands for a doctor of a particular gender or skin color or ethnicity. Some people may well feel more comfortable with providers with whom they more closely identify. Indeed, where we work, in the so-called buckle of the Bible Belt, patients often inquire about the religious faith of the doctor or nurse caring for them. While they may not insist on someone with concordant beliefs, it is reasonable to think that they may be more satisfied, even more trusting, of someone from the same general faith tradition, if not the identical denomination or sect. But a stated preference is different from a demand. The former is an expression of an inclination that may be gratified or not, whereas the latter is more of an ultimatum, in which failure to meet its indicia may or may not be met only with disappointment, but also with anger and resentment. Complicating what might appear to be a straightforward problem of accommodating or not the demands made by bigots is the well-supported observation that gender and race-concordant patient-provider dyads produce better health outcome. Now, admittedly, for the latter, these data are almost always examined among populations of patients who have historically been the victims of discrimination associated with past and ongoing health inequities. Although race-concordant patient-provider dyads may indeed be less susceptible to the implicit bias that is the major cause for many race-based disparities in healthcare in the modern age, increasing the diversity of the healthcare workforce in general could lead to similar outcomes by altering the behavior and attitudes of others. Nevertheless, are there philosophically and morally compelling differences between a woman asking for a female gynecologist, a black man requesting an African-American internist, a Mandarin-speaking patient demanding a doctor whose primary language is Mandarin, and a white person requesting a white doctor? In cases like these, one might first look for the reasons grounding such preferences. But while that may be satisfactory much of the time, in many situations the answers may simply be confounding. For example, if an African-American patient asks to see a doctor of the same race rather than a white doctor because the patient has greater trust in someone of the same general background and conversely distrusts the symbol of cultural and professional hegemony, the first part of the rationale behind the request might be disturbingly similar to the reasons given by a white person who wants a white doctor. Why should we respect one patient's prejudice and not that of the other? One explanation could be based on historical and ongoing explicit and implicit cultural and systemic racism experienced by black people in America, an experience that could be factored into a justification for accommodating, to the extent feasible, such a request by a black patient, but not by a white patient. The former could be said to be based on legitimate fears, while the latter stems almost exclusively from bigotry. And that may be the key distinction that warrants respecting one and not the other. One could use this same reasoning to reject demands for straight caregivers and other racially or ethnically biased preferences, such as religion. This analysis is less plausible, though, when applied to same gender and same language requests. However, acceding to patient demands in these domains is not unreasonable and is unlikely to offend caregivers as much as being rejected for their ethnicity, sexual orientation, or religion. Nevertheless, there is a potential trap here in this approach that could yield an outcome that many might view as unacceptable. If African American patients demanded black doctors and nurses and were accommodated, it could result in a situation that was prima facie resultant in a segregated patient-caregiver population, replicating that which existed 50 or more years ago, even if for more honorable and justifiable reasons. Finally, as far as requests regarding the gender of the caregiver, it may be valid to note a difference between requests for same-gender nurses or doctors and the legitimate reasons grounding the request, and those against a provider. We are all familiar with the cases where patients or their families refuse to be seen by a female physician, i.e. a lady doctor, or a male nurse solely on the basis of views they hold about the abilities and competency or sexuality of these individuals. These examples illustrate well that this problem is not necessarily as straightforward as one might superficially think. It's complicated. The reasons for the views and actions of people matter, and healthcare professionals should explore them rather than rejecting such requests or demands immediately and automatically. Unless there is an issue of staff safety that needs to be addressed urgently, and in my view, safety always takes precedence over other considerations, there should be time to explore the situation a bit more to gain some understanding prior to reaching a judgment that could have significant consequences for all involved. Some have also suggested that the Federal Emergency Medical Treatment and Active Labor Act, or EMTALA, requires that patient demands be met. This is patently false, as there is no language in either the law itself or the final regulations stating that patient demands, such as racist demands for a particular provider or excluding particular providers, must be met in the course of performing a medical screening exam or treatment for clinical stabilization. Whether to accommodate these demands is purely at the discretion of the treating institution, and to believe that the institution must do so is an erroneous interpretation of the law. Patients, other than those who need immediate medical attention, do not have a right to the satisfaction of their demand to be seen by a physician or nurse of a specific type. Of course, they can choose their caregivers as they see fit, and they are free to seek out doctors and nurses they feel most comfortable with, even if it is on the basis of personality or skin color. They are also free to refuse to be seen by caregivers. In the emergency department, where EMTALA's requirements are active, if they do not like the personnel who are there to serve them, they are free to leave against medical advice, as patients do all the time when they don't feel like waiting, and seek care elsewhere. The question is what to do when the patient wants to be seen and needs to be seen, just not by that person. Law professor Kimani Paul-Emile has argued that Title VII of the 1964 Civil Rights Act does not and should not cover respecting race and ethnicity-based preferences for physicians and presumably nurse providers on the part of patients, but that respect for patient autonomy requires that doctors and nurses yield to their demands. So her views are in direct distinction and against the rulings of courts in this matter. But I think she misunderstands what the power of individual autonomy rightly confers on a person in the realm of healthcare, and perhaps in other domains. It is the right to decide what happens to oneself. There is not a corollary right to have others meet your demands about what should happen to you or for certain behavior towards you. Of course, people have a reasonable expectation that they should be treated similarly to others in their clinical situation, but that is a matter of fairness and justice, not autonomy. Irrespective of whether we buy Paul-Emile's reasoning, one could plausibly argue that healthcare providers have an ethical duty to resist the racist and bigoted demands of patients as a matter of their professional autonomy and collegiality. After all, institutions presumably hire their staff members on the basis of their race, ethnicity, and gender-neutral competencies, and not because they are looking to have, say, African-American doctors exclusively available for their African-American patients and Jewish nurses available only for Jewish patients. This is not to say that there are not reasonable and justifiable exceptions to this rule, as U.S. federal courts have held in employment discrimination cases, in which they have carved out what are called, this is a fancy term that took me 3 years to remember, bona fide occupational qualifications. In other words, in certain circumstances, employers can be justified in hiring based on personal characteristics such as religion, sex, or national origin, and this may be justified to achieve aims of having a diverse workforce to better serve a diverse clientele. Such permissible and justifiable seeming discrimination can make it possible for a healthcare institution to grant the wishes of female patients who request female physicians to perform gynecological examinations, or of religiously adherent Muslim women who request female caregivers without violating the basic tenets of the law, or for that matter, both our moral intuitions and sense of professional integrity. Excuse me. Accommodating racist demands makes a powerful statement about the institution in which the accommodation takes place, not only in the moment and to the demanding patient and the rejected provider, but also in general to other members of the staff. It says that the hospital or clinic believes that complying with bigoted patient demands, basically transforming the unreasonable and unacceptable into the reasonable and acceptable, satisfying their immoral requests, is more important than respecting the dignity of both their staff members and the majority of patients who do not hold such repugnant views, or at least do not act on or voice them openly. And simply because an institution could accommodate racist patient demands does not entail that they should do so. Institutions plausibly have a duty to present a moral face to their community by refusing to honor bigoted or prejudicial requests or demands as a matter of course, up to and including declining to care for such patients, except in emergency situations. However, as I've stated before, things are not always clear-cut. It's often said to me, why can't you come up with a clear-cut black and white answer? Why is everything always gray? Well, unfortunately, complicated issues are complicated because they're complicated. So things are not always so clear-cut. We must guard against indulging our own prejudices and biases, be they explicit or implicit. I would like to think and hope that the vast majority of us are sufficiently professional that the former, the explicit prejudices, are rarely expressed, if ever, while the latter may be so subtle and widespread that we and our colleagues may not even be aware that we hold such buried views and permit them to influence our attitudes and actions. Our implicit biases could cause us to misinterpret behavior and language of patients and families that we don't understand or which we think hews to a negative stereotype, and lead us to misjudge the meaning of situations. We could erroneously assign malign intent when there was none present, and this could have disastrous consequences for patient care. It's one thing to call out and not tolerate a racist like the neo-Nazi who didn't want Tanya Battle caring for his infant son. It's a completely different ballgame to misjudge a situation or a person and infer things about him and his personal views and subject him to possible banishment from our care. We can guard against these grievous errors by engaging in self and institutional educational activities that have proven effective in both revealing hidden prejudices and through self-awareness allow us to combat them more effectively. So how should we take care of bigoted patients who wish their doctors and nurses to accord with their bigoted views? Surely these patients And people are as entitled as the less prejudiced to have their illnesses addressed, unless we wish to hold that the very fact of their bigotry walls them off from the inclusive approach to human suffering that is the hallmark of medicine. But even Nazis are capable of being sick and injured and thus stimulating our compassion for their suffering as fellow humans. Of course, autonomous individuals with decision-making capacity are certainly free to choose to seek care from providers more to their liking, unless their medical conditions preclude them from doing so in the moment, such as with people requiring emergency or urgent care. One plausible method of distinguishing between acceptable and unacceptable demands and accommodations could be an approach created in Canada, of course. The Caregiver Preference Guideline, developed by the Toronto University Health Network, can serve as a useful mechanism for assessing the difference between discriminatory requests that stem from bigoted beliefs and those that may be more legitimate and justified, analogous to those outlined by the federal courts as bona fide occupational qualifications, as I described earlier. In this method, carefully trained individuals, and I really, really want to emphasize this, if we're going to tackle this correctly, at least in my view, and we're going to tackle this problem effectively, we need carefully and well-trained individuals 24/7 in order to facilitate the way we handle these things. So in Canada, or in Toronto, carefully trained individuals follow a flow chart in which there is a stepwise determination of the underlying reasons for the prima facie discriminatory request for a certain type of caregiver. If they decide that the request can be justified within the constraints of institutional policy, legal requirements and staffing needs, and safety, then it can be reasonably met. If not, then a firm stand against it should be taken. Institutions that instead adopt a rigid, inflexible procedure that do not allow for judicious consideration of the hard cases. The easy cases are easy because they're easy. It's the hard cases that are problematic. The guy with the swastika tattoo who's the Nazi, that's easy. It's all the others that are challenging and require a little bit of thought. It's the hard cases that are not clear-cut exemplars of either permissible and tolerable requests or outright proscribed demands of racist or other forms of morally indefensible beliefs, like the swastika-bearing father's objection to having Ms. Battle care for his son, can fall prey to disregarding legitimate patient needs. Moreover, acceding to unjustified or unacceptable racist demands can hurt people, sometimes grievously. At a teaching institution, a request to prevent a student or other learner of a certain race or gender from being involved in the care of a patient could result in particularly vulnerable individuals being prevented from accessing a reasonable learning activity and being psychologically harmed because of their inexperience. Accommodating such patients and their families amounts to a statement about the values and priorities of the institution, be it a nursing home or a hospital, as Tanya Battle expressed in her lawsuit. While a central mission of healthcare organizations is to address the clinical needs of all patients, that mission does not require that institutions and the people responsible for directing them, administrators, the senior medical faculty, head nurses, nursing administration, and the like, pander to the bigoted beliefs of all who seek care. Unless the patients need immediate attention, they can take their bodies and their racist views elsewhere. It remains up to us to control the rules of permissible behavior within our institution. We must set the nominal requirements of equality between patients, families, and staff so that the minimal expectations of civil discourse can proceed. Those patients or families who refuse or cannot abide by those rules should be given an ultimatum in order to maintain order and self-respect for ourselves. Thank you. So, those of you who have vegetables to throw them now. Any questions? Discussion? Everybody did fall asleep. Nobody?
Answers.
Well, I don't know about answers, but we certainly have time for questions. Yes.
Well, I think that one of the tricky parts
play that dad with Miss Battle. Once that situation gets brought up, not only do staff know the patient's preference, but probably in that scenario, any African American nurses on that unit decided, I don't want to take care of that patient anyway. And then for their preference and their safety, we of course would put that first and then accommodate that need, you know?
Yeah. So I'm supposed to repeat the question, right?
Yes.
Okay.
Sorry, I should have been more concise.
Okay, the question is, so I think you've raised a really important, yet again, complicating factor, is that when we have clearly identified somebody whose views we find antithetical to our mission, shall we say, the Nazi who didn't want Tanya Battle caring for his son, no African American nurses would, and he expressed his prejudice. I'm quite sure the Nazi would have expressed prejudice if he could have identified other people who were against Nazi ideology, whatever his interpretation of that might be. So the problem then becomes, who in their right mind would want to take care of this child? Now, quite frankly, I think that case is a little easier because the baby isn't the Nazi, okay? But let's say it's actually the guy with the tattoo is actually the patient. And we've had that, yes, we definitely have had that. Okay, so he's lying in bed, and to the extent, we have minimal criteria for somebody having capacity, so the extent that he has capacity, we don't think he's nuts, we don't think he's demented or anything like this, and he's got his tattoos all over the place. Let's say he's got one on his forehead, and he clearly expresses, I don't want these kinds of people taken care of. Okay. So now we're faced with a quandary. If I were one of the people that he didn't want taken care of him, why in the world would I want to take care of him? Let somebody else take care of him. But by accommodating that request, we're saying something to him and we're saying something to our staff. So I think that if we were going to do this the right way, and right now hey, I'm going to retire in how many days did I say? 95 days? I don't really care. And I've got my pension and, and are there any members of the Board of Trustees here? Good, because they'll be voting on my emeritus status shortly. So I don't think we're doing this the right way. And quite frankly, we are leaving ourselves wide open, not being a lawyer, for a lawsuit. From what I've read of the federal court rulings, this is pretty clear. And the policy that we have, which nobody here, I suspect, knows that we actually have, because it wasn't very well publicized on purpose, that's another story, okay, but is currently being rewritten to make it much more robust. Times are different. So that's the good news. It's going slowly, like policy work usually does, but that's the good news. But having a policy is meaningless without having the stuff behind it to implement it. And that is going to require a major effort, as I alluded to, on the part of the administration of this institution to not only empower people, but to train a group of people who are here 24/7, 365, to be able to do, even at 3 o'clock in the morning, to be able to address these issues in a competent and uniform way. So that's what, not saying that this is the perfect way, but one of the reasons I like what they did in Toronto is that they trained people and they actually have an algorithm that they follow. And these people are trained to go into a situation, and by the way, this doesn't take 4 hours. This takes about 15 minutes or less to figure out what's going on and saying, yes, this is reasonable, no, this is not reasonable. We're going to do this in the moment because safety is an issue, and then we'll deal with everything else later in the day, including if we have to transfer the patient. So if for reasons of safety, we have to make a personnel change for the next 3 hours from 3 a.m. till 8 a.m., and then we'll figure out, and then we will put in motion what we have to do in terms of transferring the patient. or just reading the patient the Riot Act. This is the way we do things at Duke. If you don't like it, here's an AMA form. Now, that's going to ruffle a lot of feathers. That's a real change in attitude. But I don't think we have any, forget about the legal stuff. I don't think we have any choice. I think it sends a terrible message to our people when we put this kind of precedence, when we favor these views, the power of these people, over our own integrity. Most of the time it's intention. Most of the time there's some sort of this crazy balance, and we put ourselves at the service of patients all the time, but there's a line. There's a limit. One of the reasons I don't particularly care for the program at Penn State, and so Penn State started this no tolerance policy after, and this actually got in the news and all that sort of, well, at least in the news in central Pennsylvania, got in the news. They had a patient come in. Now, they are a much more ethnically homogeneous area than we are, except at the medical center, okay? And so they had a doctor, a resident, was it a doctor? I can't remember if it was an attending or a resident, who was South Asian ancestry, okay? So he goes into the patient's room, and the patient says, I want an American doctor, and kicks him out of the room. Yeah, well, no, he wanted a different kind of American doctor. He wanted an American doctor that looked like him. And that did all sorts of soul searching, and this guy was horrified, and he was really upset, and yada, yada. And so, and this is why, you know, I think this happened, I think allowing this to happen to particularly vulnerable people, new grads, interns, medical students, nursing students, other kinds of students who don't have a thick skin and can say what I'm not allowed to say. What? Oh, we can't say it? Okay.
You're going to retire, Phil. Go ahead and say it.
No, but this is going to be on YouTube in a couple of minutes. So, and I already got stuff on YouTube that I don't want anybody to see. And so they took this zero tolerance. So they're just seeing things, no pun intended, black and white, and they're not seeing any nuance or subtlety. And if you read their policy, that's the way it says. And I think if we don't allow for some sort, for the gray areas that need to be judged, similar cases treated similarly, but realizing that there's this gray area that we have to figure out a way to meet in the middle somewhere, I think that's, that carves out a space that I don't think we need to go there. But it's going to take a major committee. See, you don't need to train anybody if we just say no. Or if the answer is yes or no, we don't need to spend a lot of money and train people and do all this other kind of stuff, because who cares? I mean, you judge in the moment, yes or no. Thumbs up or thumbs down, get out of here, stay here. Yes, ma'am.
A two-part question.
Uh-oh, I don't know if I'm going to be able to repeat this.
What was the community response to the Penn State situation, or was it publicized? Did the community understand that this was now a yes, no, black, white situation?
So the question is, okay, I'm going to do it. Okay. So the question was, did the community, how did the community respond to the Penn State situation? I know it made all the local news and the papers and everything like that. I have no idea what the community said. It's the only hospital around here, so maybe they don't have a choice. So I have no idea.
Second part is there any role for community involvement, particularly community leaders of various groups, to take part in educating their constituencies about this kind of attitude or activity on the part of a major member of the community?
So the question is whether there's any role for community leaders of various communities to educate their constituencies about, let's say we upgrade our policy, et cetera. I think, yes, of course there is. I have no idea what effect that might have. I'm assuming leaders of racist communities are themselves racist, if there is such a thing as a racist, sort of cohesive community. I think it would be well served on our part for any one of a number of reasons that if we finalize this path and go into it whole hog, so to speak, that we really publicize this. This is something, if we do this, this is something that we should be proud of. And actually, if we publicize it, first of all, it will tell something to all of the community, meaning our, whatever it is, 15,000 employees, but it will also tell something, maybe that will scare off people, well, maybe I don't want to go to Duke. Now, of course, people may decide that maybe that's why we shouldn't publicize it. But if it scares off 100 patients a year because of our policy, fine. No offense, but let them go to UNC. Okay. So which, by the way, is working on a similar thing. So.
What is our policy? Good question.
The question is, what is our policy? It's whatever I say it is. So.
Well, what happens when you go?
Okay. What?
I don't have anyone to ask.
I'm going to be retired, not dead. At least I hope not. Okay. So. I actually got a text page. I actually got a phone call from one of the trauma surgeons who, it turns out, there's somebody else named Phil here also, who's another trauma surgeon. So, okay. So I want to say it was 2010, I belonged to a couple of listservs, and I heard about a case that was that came out of the Fourth Circuit Court of Appeals, which is in the Midwest. And this was a case very similar to Tanya Battle. This was at a nursing home. An old lady goes into the nursing home in the middle of the night, or 10 o'clock at night, something like this. She's white. A nursing aide checks her in. There's usually there's nursing regulations, has to be, Medicare says there has to be an RN on duty in charge. So this is the middle of the night. Nursing aide comes in, checks her, starts to check her in, and the old lady says, I don't want this person taking care of me. The nursing aide was African American, and I want somebody who's white. The nursing supervisor says, okay, we'll switch around the nursing aides, and the nursing aide who got punted aside sued. Also under Title VII in the 1964 Civil Rights Act. She wins, and she did not, I don't think she filed a complaint with the EEOC, but she filed a lawsuit against the nursing home corporation. In federal district court, she wins. The nursing corporation appeals, and it goes to the appellate court, which unanimously rules that this is workplace discrimination. And so I heard about this case, actually only about 2 weeks after the decision came out, and so I said, I wonder what we do here, since I had been acquainted with several cases where that I knew about, plus the subculture of this stuff happening all the time that I didn't even hear about. And I heard about it in doctors and nurses. What is our institutional response to this? It turns out we have none. So I joined up with Cynthia Clinton, who at the time was legal staff in the Medical Center Office of Institutional Equity, is now the Associate Vice Chair, Dean, something or other, of University Institutional Equity. And we wrote a very, very simple policy. We said, Duke, it actually had, I believe, 3 sentences. Duke University Medical Center hires people on the basis of their credentials and not on any of these other characteristics, just like I said earlier. And racist and discriminatory requests will not be tolerated. Something like that. There might have been one other sentence. That was the beginning of a long journey. I actually wrote a paper about this, and it got published. It was called Sausage Making, based upon the probably incorrect assignment of a quote to Otto von Bismarck, the iron chancellor of late 19th century Germany, who was reported to say nobody wants to know how policies and laws get made because just for the same reason that you don't really want to know how sausage is made, because you like the result. You may like the result, but you really don't want to know how it got made or what goes into it. This went through numerous iterations, including a knockdown at the very, very highest level for patient-centered care, patient satisfaction reasons, and it got sent back to the drawing board. So if you go to the policy center and look under discrimination, you can find the current policy. It sort of says we don't put up with this stuff, except when we do. There's no teeth, there's no publicity, and there's no mandate that we do anything to train people how to deal with this. So things go on unchecked. Now, to their everlasting credit, the former chief, one of last year's chief residents in the Department of Medicine, whose name I can always never pronounce, who was over at DRH, one of their interns or residents had this happen to them. And that started her on a crusade. And so she and Laura Svetke, who's one of the vice chairs of the Department of Medicine, contacted me and said, do we have any policy? And I said, well, funny thing, you should ask. We do, but it doesn't really seem to do any good or mean anything. And so we have been working with the Department of Medicine, which has engaged in this whole training program strictly for the Department of Medicine called Civility, what are they called? Civility Champions or something like this, to go around and try and help these situations. But that's only for the house staff and for their faculty. It has nothing to, which now, Department of Medicine is a big department, but the nursing department swamps the Department of Medicine. The schools, everything. I mean, there's a lot of people who walk through this place that need to be brought under the umbrella of such a way of dealing with such situations. So we've been working with hospital leadership, and we have good reason to believe that current hospital leadership and health system leadership is considerably more open to making a stronger statement and backing it up than it was 9 years ago, or 8 years ago. But these things go very, very slowly. So this will undoubtedly be left to whoever takes over for me, and Laura's not retiring for a few more years, so she can see it through. But it's in the works. Any other questions? Comments? Anything?
Thank you.
Thank you very much.